Hello, my name is Diana Smith, and I'm here tonight to present the results of my project, Improving Patient Care with Increased Identification of Patients for Medical Cannabis Use. Committee members. My committee consisted of 2 members. First, my chair, Dr. Ashton Lindsay, DNP, and second, my community member, Dr. Lori Connolly, MD. Background and significance. Before I delve into the background and significance of the project, I'd like to give a little backstory on the project of how this topic came to be, how this topic found me, rather. I'm a family nurse practitioner, and I practice family medicine in a small rural community. I had a patient who came into my office requesting a renewal of her medical cannabis card. I kindly explained to her that that was not a service that my office offered, but I would be happy to refer her somewhere that would. When she asked why we didn't offer that service, I didn't have a good answer for her. My colleagues and I had previously decided and previously agreed that medical cannabis was not something that we were going to offer for many different reasons, but mostly because we didn't know enough about it and we didn't have enough experience with it. After this interaction with this patient, I really realized that I was not offering my patients the best possible care because I was withholding a treatment option, not for any reason to do with the patient or with the treatment option, but I was withholding it because I had a lack of knowledge, and that was a problem. Now for the background and significance of the project. The purpose of the project was to increase the identification of qualified patients for the use of medical cannabis by educating healthcare providers in Iowa on the qualifying diagnoses of medical cannabis, the authorization process in the state of Iowa, and on patient education. To date, only about 3% of nurse practitioners in Iowa have authorized at least one patient to receive medical cannabis. There is currently no certification or no CME, continuing medical education requirement, for a provider to authorize a patient to receive medical cannabis in the state of Iowa. And about 1/3 of healthcare providers felt that the education available was insufficient, and yet 53% of those same providers reported that they had counseled patients on the use of medical cannabis. Review of the literature. As I reviewed the literature, there were 3 central themes that really came out repeatedly over and over. I will take a look at each of these themes individually. They were lack of education, confusion on qualification requirements, and difficulty with identification of patients. Lack of education. This was really a 3-tiered problem. First, more than 90% of providers surveyed felt that they were not confident in prescribing medical cannabis, largely due to the inability to identify patients correctly. Secondly, greater than 50% of medical residents reported receiving little or no education regarding medical cannabis while they were in school. And thirdly, more than 75% of primary care providers expressed interest in additional education. So when we really look at this is a service that's not being offered because we can't identify patients. We can't identify patients because we were never taught about it. And even though we weren't taught about it, we are asking to be taught about it, and we still are not receiving the education that we need. Qualification requirements. There's a lot of confusion regarding qualification requirements of medical cannabis because there is a big variation from state to state. Each state that has a medical cannabis program is managed by its own state, typically by the public health department in that state. So for example, in the state of Illinois, there are greater than 50 conditions that would qualify for the use of medical cannabis, as compared to Texas, where there are currently only 8 conditions that qualify for the use of medical cannabis. In Iowa, where I practice, there are 14 conditions on the approved conditions list. It's also been shown that only 5% of providers were aware of their state-specific qualifying regulations and qualifying diagnoses. Identification of patients. The problem with identification of patients is really twofold. First, providers are not able to identify patients. Most providers could correctly identify some of the qualifying diagnoses on the list, but none of the providers could correctly identify all of the qualifying diagnoses on the list. In particular, there was significant lack of education surrounding PTSD, post-traumatic stress disorder, and TBI, traumatic brain injury, as qualifying conditions. The second half of this problem is that not only are they not identifying patients, but when they do try to identify patients, they're identifying the wrong ones. It's been shown that providers often incorrectly name conditions that are not on the approved list as being qualifying diagnoses. Most specifically, this commonly happens with anxiety, depression, and Parkinson's disease. And finally, thankfully, it has been shown that when these providers are given a proper and appropriate education around medical cannabis use, medical cannabis qualifying diagnoses, and the authorization process of medical cannabis, greater than 75% of the providers could then correctly identify patients, as compared to 41% who could correctly identify patients before that educational intervention. Theoretical framework. By utilizing a theoretical framework to really help establish and set up this project, I was able to not only focus on my goals as I went through the project, but also really able to translate it back to practice and actually make it something that was usable for my office. The framework that I selected was the Knowledge to Action model that was developed by Dr. Ian Graham and his colleagues at the University of Ottawa. This is the model, and as you can see when you look at the model, knowledge is created at the top of the triangle in the center of the diagram. And as the knowledge is created and as it is refined and as we ask more questions, this knowledge is synthesized down until it's really something that can be utilized. After the knowledge is completely synthesized down, it comes to a point where we can now put it into practice and we can use it. That's when the knowledge exits the center circle and now breaks out into the outer circle. From here, the knowledge ebbs and flows through this ring all the way around the outside. We evaluate the outcomes, we assess the barriers, we look at different interventions, and we really do adjust this to the way that we need to use it. We continue to monitor the results as we use this knowledge. This model really focuses on synthesizing the knowledge and implementing it into practice. And to simplify this and to state it more directly, this model describes that as knowledge is created and refined, it's adapted to the local context and customized to be best utilized in that specific context. Method and design. A quantitative exploratory design was used for this project. There was no engagement of any participants. This was a retrospective survey review that analyzed data from previously collected anonymous surveys to evaluate the success of the project. These were surveys that were completed by the healthcare providers who were providing direct patient care at the time of the appointment. The retrospective survey format was chosen to provide the highest level of protection for the patients who were utilized in the study. I decided to emphasize the confidentiality for these patients because I do work in this office and I do see some of these patients myself, and so I wanted to make sure that there was absolutely no risk of breach of confidentiality for these patients. I also chose this method because it was the most simple and direct way to answer the question that I was looking at without overcomplicating. I did have some difficulty early on when I was trying to nail down the method and nail down the design of the study, and I was trying to overcomplicate things, but thankfully my committee stepped in and was able to help me simplify things so that it was a much more direct question and therefore a much more direct answer. The project sample. The patients that were used in this project were patients who were visiting a rural health clinic in the Midwestern region of the United States during the selected time frame. The ethnic demographic in this area of the United States is approximately 90% Caucasian, 5% Hispanic, and 5% other ethnicities. So it is assumed that the patients in this sample were of the same demographic breakdown. The patients for this project were identified as having one of the 14 qualifying diagnoses that have been approved in the state of Iowa. These patients are of any gender. These patients are only age 18 to 75. And finally, there was no restriction on insurance or self-pay status in the patients that were included in this project. Data analysis. For this project, I did compute a z-test for the difference of two proportions. What that's really looking at is comparing two ratios. It looks like this. The first ratio on the left is the number of surveys returned prior to the educational intervention over the total number of patients seen prior to the educational intervention. We compare that to the second ratio on the right, total number of surveys returned after education over total number of patients seen after education. This was chosen because it was the most simple and most direct way to answer the question that I was looking at. The z-test for the difference of two proportions is a one-directional test, meaning that it does not look to see whether there was a change up or down in the ability of providers to identify patients. I was only interested to see if providers could increase their ability to identify patients. So this is a one-directional test used to see if an event occurs equally in two populations. So we're looking to see if it was equal or if it had increased that providers could identify patients after the educational intervention. Results. The first graphic shows us the percentage of visits identified as being appropriate for the use of medical cannabis. Prior to the educational intervention, providers identified 4.6% of visits as being appropriate for the use of medical cannabis. After the educational intervention, they identified 15% of visits were with patients who would qualify for medical cannabis use. So it more than tripled after the educational intervention. The second graphic looks at the qualifying diagnoses that was identified by the provider. The inner circle shows pre-intervention. Providers were able to identify 3 diagnoses. The outer circle shows post-intervention. The providers were able to identify 5 diagnoses, 3 of which were new as compared to pre-intervention. And the last graphic that we're looking at shows us the follow-up appointments scheduled by percentage. The inner circle shows us that 0% of patients scheduled a follow-up visit to discuss medical cannabis prior to the educational intervention, even if they had been identified as appropriate for medical cannabis use. There was no follow-up appointment scheduled. After the educational intervention, it shows us that 7% of the visits then scheduled a follow-up appointment to discuss medical cannabis. Limitations. As with all research, this study did have limitations. First, due to the anonymity of the survey style of this project, there's potential that a single patient, was included more than once in the count. This may have happened if a patient had more than one office visit during the selected time frame. This could mean that they may have been included more than once during each of the 2 time frames and potentially could be included in both time frames as well. Secondly, patients younger than age 18 and patients older than age 75 were excluded. However, under current Iowa legislation, they could potentially be candidates for the use of medical cannabis with certain qualifying diagnoses. Finally, and perhaps the most important, is that the project's time frame was shortened to accommodate providers' scheduling issues. This did significantly reduce the total number of patients that were included in the project, but it may have also had an impact on the demographic makeup of the patients. It may have happened to adjust the demographics because the pre-education patients were seen during the first half of a month, and the post-education patients were seen during the second half of a month. This could have impacted the demographics based on when patients are able to go to their doctor's office. Some patients have to limit times that they have appointments due to finances surrounding co-pays or transportation issues or things of that nature. And so by having to do the scheduling and having to do the time frame the way that we did, this may have impacted the demographics as well. Discussion. Following the educational intervention, the provider's ability to identify patients improved, the number of qualifying diagnoses identified increased, and the number of follow-up appointments increased as well. These things were all important for different reasons. The ability to identify patients definitely allowed our providers to offer better care to our patients and actually offer a service or offer a treatment option that was not being offered to them prior to this educational intervention. The number of qualifying diagnoses identified improved the care and allowed us to have more meaningful conversations with a greater number of patients. And the follow-up appointments increased was important because not only are we losing less patients to follow-up, it also increased the office's productivity as a whole, which meant more nurse visits, more appointments for the office, and increased revenue for the office as well. Originally, it was estimated that a potential 10% of the office visits were with patients who would qualify for the use of medical cannabis. But I found that after the educational intervention, providers were able to identify 15% of the patient visits as being encounters with patients that may qualify for medical cannabis. So this was a significant increase even over what I expected to find before starting this project. Implications for practice. This project is allowing for ongoing integration of medical cannabis-related topics into future educational sessions, not only for the providers in our office and for the staff in our office, but also for future students and for future providers. This project is also helping us to be more inclusive in our conversations with patients, offering medical cannabis as a treatment option that was never offered to them prior to this educational intervention. So we're offering them and we're providing them with a more comprehensive care as a direct result of this project. Also, this project is now encouraging information regarding medical cannabis to be included not only on patient intake forms, but patient pain assessments. Also, it's been modified and weaved into the scripting that our nurses and our front office staff use when scheduling patients and when doing the intake paperwork, Finally, these resources, including the toolkit that was given to the providers at the time of the educational intervention, as well as the slide deck that was utilized for that educational intervention, will continue to be available for future use, not only for current providers and current office staff, but again for future providers who may be hired down the road. This information will be available not only in hard copy in the new provider manual binder that is kept in the office, but it will also be kept in the virtual provider library on our secure database. As legislation and as laws are changed in the state of Iowa, this information will be updated so that providers can always be kept with the most up-to-date information. Conclusions. The result of this project is that there was a statistically significant increase in healthcare providers' ability to identify patients for the use of medical cannabis following an educational intervention. There was also an increase in the number of qualifying diagnoses identified by healthcare providers. There was an increase in the number of follow-up appointments that were scheduled to discuss medical cannabis. And there was an increase in the completion of authorization paperwork. As a direct result of this project, my office did authorize its first 3 patients for the use of medical cannabis. The result that I'm the most proud of for this project is actually not listed on this screen. The result that I'm the most proud of for this project is that the providers in my office are now more comfortable discussing medical cannabis not only amongst colleagues, but also with patients. This allowed the providers in my office to be more comfortable having open and honest conversations with patients regarding a previously unutilized treatment option. Patients, colleagues, students have asked me throughout this project why I'm so adamant about medical cannabis being used, and I have to correct them and explain that I am not here to convince anyone that medical cannabis is the correct treatment option for any patient. However, I am here to advocate for the fact that if a treatment option is being withheld from a patient simply due to a provider's lack of education, that is a problem. I recently had one of the providers in my office who's nearing retirement state that he is quite pleased that I was able to teach an old dog new tricks, and while I can't necessarily agree with that, I am pleased that I've been able to improve the care that we are providing the patients in my office. If there are any questions that anyone has, I would definitely love to hear them. I'd like to thank you all very much for viewing my presentation, and I do look forward to answering any and all questions, and I do appreciate feedback that I know you will all give. Thank you so much. These are the references that I utilized in creating this presentation. Hello.